Good afternoon, everyone. It's been a long day, so thank you. We really appreciate you joining us for the last session. My name is Karishmah Bhuwanee, and I'm an economist on the Health, Finance and Governance Project. Throughout the day, you've heard a lot of discussions about a whole spectrum of health system strengthening interventions and achievements. And in this session, we aim to combine those discussions and reflect a bit on what that means for the future of health system strengthening. Countries have set some really ambitious targets, like universal health coverage, to ensure that their population gets the services they need. But they'll be trying to achieve those targets in the context of some really complex challenges. For example, increasing cost and demand for healthcare, decreasing development assistance for health, and also increased vulnerability of health systems as systems become more and more interconnected. And so, as we've heard today, achieving these targets really requires a focus on the underlying health systems, and focusing on service delivery will not be enough. I wanted to share a couple of thoughts with you as food for thought, a few emerging or recent trends. First, the increasing use of alternative financing mechanisms. So, for example, development impact bonds, corporate social responsibility, taxes on financial transactions, and sugary food and drinks. These alternative mechanisms to try and dedicate more funding for health. The second is a move beyond a traditional approach to health towards a more multisectoral approach. So really seeing health sector stakeholders at the table for a broader range of discussions. For example, education, sanitation, gender equality, and also learning from those different sectors. And finally, the more prominent role of technology in health. As you reflect on these thoughts, I'd like to introduce my panel. I'm really honored to be with such an esteemed group of speakers today. To introduce them, I wanted to share some of their baby pictures. You're probably wondering why I would want to share their baby photos, but let me explain. I will share their professional baby photos. So these are the panelists' first assignments in health system strengthening, and which kind of led them to dedicate their career to this field. So maybe you'll be able to guess which photos belong to which panelist. So for my first panelist, I will share excerpts from a poem that an ex-colleague wrote for her. And this was as her role as an epidemiologist in the Department of Health and Human Sciences in North Carolina. You've given of yourself now and before when you spent 2 years working in the Peace Corps. You did your first college work in the town of DC, then went to PA for 2 graduate degrees. And then all that time that was certainly well spent when you helped all of us with our LHD assessments. Now it's back to the capital where your work can be paid as you give your time to USAID. It is, of course, Kelly Saldaña. Kelly is the director of USAID's Bureau of Health Systems. For our second panelist, I'm going to show you pictures of her first assignment, which was here. You're looking at the planning unit of the Ministry of Health in Lesotho, where she was conducting a costing study. And she had to travel to very remote parts of Lesotho and traveled using the Flying Doctor helicopter that you see in the background. Our second panelist is Sara Bennett. Sara Bennett is a professor of international health at the Johns Hopkins Bloomberg School of Public Health, and she's also the assistant director of Health Systems Program. Last but not least, the final panelist, Susna Day started her first assignment in health system strengthening here. This is the Ministry of Health in Ethiopia, and she was working on USAID's Essential Services for Health. You can recognize her. Still looks the same. Susna is the Senior Program Advisor in Health System Strengthening at the Bill and Melinda Gates Foundation. She manages a portfolio of work for Nigeria and has traveled there recently with both Bill Gates and Melinda Gates. So welcome. Thank you so much for being here. So I'll go straight to my first question. Health system strengthening has seen a lot of transformation since you started working in this field. Going forward over the next 5 to 10 years, what do you see as the one biggest challenge and the one biggest opportunity?
Okay, thank you. So I want to start out by saying we reviewed the questions that everyone submitted over lunch, and there were just so many questions. So I don't think we're going to get to all of them, but I've tried to incorporate a couple of answers into what I had planned to say for this question. And I think to start out, in my mind, opportunities and challenges really are the same, two sides of the same coin. So what is an opportunity also brings with it challenges. So a couple thoughts on that, and I touched on some of that this morning, is I think there's a growing recognition of the importance of health systems. I think we're moving away from this tension between short-term results and long-term results. I think increasingly, as countries do better with the low-hanging fruit of tackling disease burden and mortality issues, going that next step requires both long-term and short-term attention. So you increasingly need systems-based approaches in order to continue to move forward on our global health challenges. And so I think that's a really good opportunity for health systems in this space to really sort of take ownership of where we're going in health. But that brings with us a challenge, because as everybody starts turning towards health systems, we're challenged to how do we speak with one voice as a community on health systems? How do we ensure that health systems has a common lexicon across what everybody is doing, sort of a common set of interventions that we know work, a common set of approaches and a shared understanding of how to implement those programs? I think that's the challenge. And I think, as we touched on today and this morning, some of the work that HFG has done helps us to begin to start overcoming those challenges. I think universal health coverage and establishing clear goals for where we're going with health systems in terms of achieving financial protection, looking at equity in health outcomes across the population, ensuring that those outcomes are achieved with some standards of quality. I think identifying key concrete results that we're working for help to get us there. I think it still helps to move us away from focusing building block by building block and starting to think about the broader complexity of health systems and how do we engage different aspects of building blocks to really drive towards those outcomes. But I think as we start to focus on results, the challenge that then comes with that is this expectation of constant progress. And I think that's a challenge for health systems. As we know, one, it takes a long time. Some of the examples that were highlighted today go back years, even before the start of HFG, and we really need to have some patience with health systems. We also need to recognize that some of the things that we measure as progress on health systems don't always move in a direct linear fashion. And so, for example, you can work to increase demand for health services, which in the short term might increase out-of-pocket expenditures if you haven't set up the system to address those out-of-pocket expenditures. And so it's not necessarily always bad when out-of-pocket expenditures go up. We don't want them to go up, but at the same time, we have to, I think, understand that sometimes there's sort of an expansion and a contraction of what we're trying to achieve in health systems. I think the same can be said for equity. Which sometimes we can have increasing inequity in order to make overall progress. And I think finally, I'll just note that, I think it's not just this linear progression, but it's also the vulnerability that health systems have and how we make sure that they're resistant to a range of shocks that can happen. And so it's not just natural disasters or disease epidemics like Ebola, but political transitions can have major impacts on health systems as well. So when I was maybe not quite a professional baby, but a toddler, when I started at USAID and I was working on health systems in the Latin America Bureau, I think one of the countries that we looked at as having a strong health system and having a model that other countries could look up to was Guatemala. They had an extension of coverage program which looked at contracting out health services to indigenous populations in the Western Highlands who'd been left behind after 30 years of civil war. It was a program that was very effective at extending coverage. They had a series of governments who were very supportive of that program. About 4 or 5 years ago, a new government came in and decided that they didn't want services delivered by anything but the public sector anymore. And almost overnight, services were cut off for the most marginalized populations in Guatemala because they'd never built up the public infrastructure to reach those. And so that's an example of where a strong health system can be weakened relatively quickly, not due to a disease outbreak, not due to a natural disaster, but just due to a political change. And so I think, we also have to think about how do we address that aspect as we move forward in health systems.
Mm-hmm. Thank you. Sara.
Thank you very much, Karishmah. So I think one of the things that a project like this does a lot of is looking at evidence in country contexts, trying to interpret that evidence and to strengthen decision-making based upon that. But as many of you will know, and I think this was sort of the term was first coined in the run-up to the SDGs, we're going through something called a data revolution. And by that, I mean that there's more sources of data and information than I think there ever have been before. And perhaps along with that, more sources of misinformation than maybe there ever have been before. And I think that there's also a much broader array of users of that evidence and information than we've ever seen before. And I think a sort of process of democratization of access to information. And I think that that has really important opportunities for health systems and health systems strengthening. When I started out, I don't quite go as far back as Bob Emery on these projects, but I do go back to PHR, to the Partners for Health Reform. And around that time, there was a data for decision-making project, which I think was really very much focused around how do key health system or health sector managers use data in their day-to-day business. And that continues to be important, but I think one of the things that we've heard an awful lot about today is about other stakeholders, such as politicians, parliamentary committees, civil society organizations. So this process of opening up evidence and data about health systems problems, health systems performance, and allowing a much wider set of actors access to that information enables them or empowers them then, I think, to intervene and to contribute to health system strengthening. And whether that's through arguing for additional resources in Parliament, or whether it's really holding governments to account to deliver on particular services, depends upon their role. But to me, that seems a huge opportunity, and I think that something we all need to be thinking about, particularly in this context of transition. The second area that I was going to comment a little bit about, and actually you picked up on it in your opening remarks, Karishmah, was around multisectoralism. And personally, in framing this as a challenge, because you asked us to talk about an opportunity and a challenge, so I agree with Kelly that they're different sides of the same coin. But in terms of a challenge, I think that many of us health system experts are too inward-looking, too focused upon the health sector rather than thinking about other sectors. And yet, when I look at the challenges that health systems are going to face over the next 10 to 15 years, thinking, for example, about transition and sustainability, I think that we heard very clearly from the chiefs of party this morning that some of the things that are really important to ensuring smooth transitions are issues around promoting political will. And again, I'm going back to these sort of questions of working with parliamentary bodies, working with civil society, but also working with ministers of finance and ministers of planning. If you take another area where clearly USAID is investing, and the US government more broadly, a fair amount of money at the moment, is around global health security. And in my mind, when I'm thinking about how do we ensure effective responses to outbreaks and early surveillance, early warnings systems, I think we need to have much closer collaborations with departments of agriculture, with armed forces maybe, departments of environment. And the story goes on. If you think about non-communicable diseases and the causes of that, then it's very clear that we in the health system need to be collaborating and coordinating much more effectively with other sectors. So I think that this notion of interdependence between sectors is absolutely critical. It's underlined again in the SDGs. And one of the big challenges, I think, for health systems moving forward is how can we really create the skills and capacities within the health system to be able to manage these kinds of relationships. And indeed, I think it could even sort of strike at our core understanding of what a health system is. Kelly mentioned that we looked at the questions that came in, and there were a lot of questions about those WHO building blocks, which are beginning to get a little bit old now. And I'm wondering whether we need to think about refreshing them, and if so, how do we define the scope of a health system, and how do we ensure that the importance both of communities but also linking outwards to other sectors is embodied in our frameworks?
Thank you. Susna.
Yes, no, thanks. And I would like to perhaps start by actually maybe focusing on the other side of the coin when it comes to multisectoralism. Sara was mentioning that there is a challenge. I think also that there is opportunity with respect to thinking in a multisectoral fashion. If you think about health system strengthening, I could never understand why we always framed it as a single sector issue. Health system strengthening deserves to have a multisectoral response, much the same way that we've tried for HIV/AIDS and other areas. And I think now, compared to, say, the 30 years ago when many of us started, well, not me, not that far back, but many of us started in this field, there weren't as many tools out there. And now there are 1,001 different tools, not just within the health sector, but within the multisectoral space. So there's integrated financial management systems that are being rolled out in governments across Africa and other countries as well. And how can we piggyback onto that when we're thinking about resource tracking, rather than creating a new, say, resource tracking module for it through the DHIS? There's also payroll reforms in terms of information systems. Rather than creating our own human resource for health information system, how can we piggyback onto what public service commissions are doing in governments, again, across the world? And if you tag health-related data to those payroll information systems, you get much more accurate data. Another aspect of these multisectoral tools that are out there, digital financing. You can use those for looking at health insurance and paying healthcare workers in remote areas. So I think there is also this wonderful opportunity that if we start to remove our health sector hat and think with a multisectoral lens, we'll realize that there's a ton of different multisectoral tools that we can also choose and adapt to for the health sector. But going back into, say, to challenges, again, it's two sides of the same coin. I think if we think about challenges from the country perspective and then from our own perspective as TA providers, in terms of the country perspective, I think the main issue that we face is governance and leadership. In those countries where health system strengthening has been impactful and successful and long-term, it really boils down to governance and leadership, that if a decision is made, somehow the decision is acted upon and implemented. And that can be done through TA and so forth, but really that country governance and ownership of the issue and wanting to find solutions is very, very critical. And so I think this is some of the success stories we hear from Rwanda, Ethiopia, Thailand, Turkey as well. But I'd also like us to think about our own evolution as we go forward in these next 5 to 10 years as health system strengthening TA providers. Should we also change the way we do business as well? What's our own willingness to respond to the complexities of health system strengthening with maybe complex solutions? Often we go in with maybe 1 or 2 interventions. We focus on 1 or 2 building blocks. We come in with a disease lens. And so we're sort of grappling in the dark, touching perhaps one part of the elephant, but not necessarily sitting back and viewing the entire elephant. And what is it that we can do? Sometimes it's a hammer in search of a nail. And to that extent, should we also think about evolving and becoming much more flexible ourselves? This is also a question for donors as well, to allow for that flexibility to come in. And to what extent can we start to work more directly as well with a lot of the capacity that has been built over the 30 years in many of the countries that we've been working in, directly with local institutions, local regional institutions. And I think as we think about capacity building as well, make sure that we're not capacity filling. And this, again, I think is also, donors have a role in this because we sometimes are very demanding for deliverables. And we have to have that patience that Kelly is talking about in terms of allowing the countries to truly own. And it might take time. It might not be so clean cut. Making sure that the countries are leading in the analysis. It's not just the technical firms doing the analysis. The countries are driving the analysis and doing that. So I think that is a challenge for us because I'm not sure that we have evolved as much in terms of how we provide TA, but it's something to think about going forward because there's been a lot of good work that we can build upon.
Thank you so much. You provided a really diverse set of opportunities and challenges, which demonstrate some of the complexity of HSS, but also a lot of opportunities. Now, before lunch, you all submitted lots of questions, very thought-provoking ones. It was quite a challenge to pick them, but we've tried to pick 3 questions that captured some of the emerging themes that were coming out. The first is around domestic resource mobilization. And Susna, I'd like to ask you about this. We hear a lot about domestic resource mobilization. What does it really mean? How do we do it responsibly? And how do you see that linking with country transition?
Oh, thanks for this. And this is hopefully not repetitive with the earlier session, and it is a very loaded set of questions. But I think, to me, and we've conferred as well amongst the panelists, domestic resource mobilization is about growing the pot of funds that are available for health, but from public as well as private sources. And I think we often forget the private sector side of things. And it's important that we appeal to the private sector in the sense, not just their corporate social responsibility mandates, but to ways in which we can affect their bottom line as well. How do we get private sector to sustainably contribute to funding for health? The other aspect of domestic resource mobilization is the mobilization part. We talked a lot today about increasing budgets for health. We have to go further. Once those budgets have been pronounced as official, are those budgets released? And how are those budgets used? And how are those funds used? And are they used in the most efficient manner? And so I think this mobilization aspect of that term is very critical. Are they spent well? I think one of the things that Bill Gates has now been forcing us to start to think more thoroughly about, he's looking at per capita spending on health across various countries, and he's wondering why the outcomes are so different. And often I say you might have the same ingredients. Like in Nigeria, we have a thriving economy there. We have a ton of healthcare professionals, extremely educated, and yet we spend so much money, but the health outcomes haven't changed in the past 25 years. And so it's not just about getting more money. It's also about, it's like the ingredients for a cake. It's finding the right recipe. What do you do with those funds once you've actually got them? Once you've allocated and raised more money, how is it that you're going to actually use them? The other aspect and related to that issue is the issue of doing so responsibly. So when we advocate for more money for health, sometimes we've come in because, again, of different parameters that maybe we're advocating for more money for family planning, more money for HIV, and so forth. How do we do so responsibly? Keeping in mind that, especially with governments, it's about hydraulics. You can be advocating for funds in one area, but let's hope that we're not taking away from education, for example. So putting yourself in the minds of the Ministry of Finance and trying to be as objective as possible, because you also don't want to have HIV competing with family planning either in terms of a limited source of funds. And so I think when we think about doing or supporting domestic resource mobilization, we really need to think about the hydraulics. We need to think about being objective in how we support and inform governments, so that governments can look at the range of advocacy issues that need to be funded, and they can make an objective decision. And so that's one element of DRM that also then ties to this issue of transition. And when we talk about transition, I think it's another way of going about this very complex process is not necessarily about, I need to transition my stuff. What I've been working on, it needs to be transitioned to the government. Let's start again by putting ourselves into the country context. Where is the country at? What are they interested in? What fits into their agenda? And assess their fiscal space first. And one thing, as we think about transition, let's think about transition from the beginning. I remember reading some of the early papers from USAID in the sense when they were talking about transition from Latin America, the ones that really succeeded well were the ones that had built in an exit plan from the beginning. And there was this open dialogue with country governments from the beginning. And so if you think about exiting from the beginning and the fiscal space from the beginning, it will also temper how you deliver your intervention. You might not go for a very expensive intervention. You might go for a much more cost-effective intervention that could be financially transitioned later. Then I've also been involved in the transition process of staffing, donor-funded staff in Namibia. And as we did that, I think one of the other things, especially as external partners, is that you also have to let go a little bit. Some of your interventions may need to be phased out, and that's okay. And some of your interventions may not be sustained exactly how you had run it before, and the government may choose to modify it. So, for example, we had, I think it was HIV commodity logistics officers at the regional level. The government said, okay, we won't necessarily absorb those people, but we will reallocate that function to the regional health bureau manager's role at that time. And so that was very hard for many of us who were working on the donor side, because we said, no, you must take our intervention as is. And so I think the other aspect relating to DRM, if we're talking about true transition, true country ownership, countries are going to do it in their own ways, and we need to work with them with their country context. And finally, one thing I'd also like to mention with respect to transition and domestic resource mobilization is that, and this is more again for donors and stakeholders who are involved in this, is that we have to be consistent with our messaging in this area. When we were talking about transition in Namibia in 2009, they had already heard about transition a few years before that. And so they weren't really sure whether we really meant it this time. And they looked at us and said, really? Are you really going to transition? And we had to get the ambassador involved and engage. We said, no, funding is really going to drop. And then funding did drop. But I'm also now hearing that donors are re-engaging and wanting to now rehire a lot of the healthcare workers that we had also transitioned, in 2009. And I've gotten comments from the Namibian government to that effect. See, this is the third time you're talking about transition now to us. And so I think consistency in messaging and making sure that all the donor partners are aligned so that it's not if one donor transitions out, then another steps into that same space. We have to have the same messaging. So that coordination is really key. That's just a few tidbits for me.
Thank you. Sara, I wanted to ask you about the private sector. We heard a lot about collaboration throughout the day. How do you think governments can leverage the private sector to accelerate progress for UHC?
Yeah. So I think it's a great question, and it's absolutely coming from the right place, because I think in many of the countries, maybe all of the countries that I work in, it would be impossible to achieve UHC without involving the private sector. And it's striking, actually, we haven't talked about, at least in this room, the sessions I've been in, we haven't talked about it a great deal. But I think that it's obviously critically important in terms of sources of finance. So we know that there are very large amounts of money coming out of pocket and going to private healthcare providers. But we also know that in many countries, there's very substantial private providers, a sector of private providers. So I'm working quite a lot in India at this point, and I think one of the key challenges there in terms of working with the private sector is the huge heterogeneity within the private sector. So you range from Apollo hospitals offering super specialist services to medical tourists, as well as to very rich Indians on the one hand, all the way down to informal healthcare providers, people with really no medical training who are offering services in very sort of small shops and stalls. So there's obviously a sort of issue around horses for courses. If we're going to engage the private sector in achieving UHC, then we need to use the right strategies to engage the right parts of the private sector, or we need to match the strategies to the private sector. In my view, there's not really a shortage of strategies. I mean, I see different countries experimenting with public-private partnerships, thinking about how can we actually bring private sector capital into the health sector, allow private corporations to manage hospitals for government, and then use that as a way of strengthening efficiency and service delivery. I also see, and I know that HFG has done work in this space, really interesting initiatives thinking about how can we strengthen purchasing functions so that they're better able to purchase quality services from the private healthcare sector. And I think as we move towards UHC, and hopefully there's a greater consolidation of funding, then those kind of possibilities become more real and perhaps more effective. I think the challenges are probably biggest when we're thinking about those small-scale, scattered, informal healthcare providers. In particular, contexts like India, Bangladesh, but also Nigeria, where there's many providers of that nature, and perhaps even more critically, poorer households are very dependent upon them. And I see experimentation there. I mean, I see people experimenting with training. And some governments, I know, for example, the government of West Bengal now has a sort of formal training policy around informal healthcare providers. So I see training interventions, I see franchising interventions, some sort of attempts to link through mHealth. So there's certainly experimentation in that space. But I'm not clear that we really have strong, effective, and scalable strategies for working with those kind of providers. But I think, in my view, really the biggest issue in terms of working more effectively with the private sector is around government's capacity to engage private healthcare sector effectively. So, over my career, I've seen lots of initiatives to try and contract out services to private providers, but the terms of the contract are often not well thought through. There has been very little, if any, sort of market analysis done to understand which private healthcare providers are likely to want to bid on a particular piece of work. So I think that there's very concrete capacity needs for government, but also Kerry, in the previous session in this room, began talking a little bit about some of the soft factors in terms of the relationships between public and private sectors. And she was referring to things like trust. And I think that continues to be a really big issue, that government officials often see private providers as in it for the money, which they may be, but then there may be ways of working with that, of aligning incentives. So I think that building stronger communication between the two sectors so there's more mutual understanding of what each is trying to get out of it, and also really developing government capacity to manage a diverse set of strategies to engage with the private sector will be really critical going forward. But the importance of that area is really key.
Mm-hmm. Great, thank you. Kelly, I wanted to ask you about human resources for health. This is really key. But we know that there's a deficit of healthcare workers. How do you think we can manage this deficit under resource constraints while countries are undergoing transition? And for example, how do you see the role of the community and community health workers as well?
Sure, thank you. Yeah, I think human resources for health is very interesting because it's almost the perfect example to tie together many of the themes that we've covered over today. So first of all, yes, there's something like an 18 million health worker shortage in the countries that we work in. And, if you start thinking about how you're going to fulfill that gap, there's a variety of strategies, but they have some important implications for mobilizing resources and financing, the role of the private sector, multisectoral issues, and sort of the full gamut. And I also think they also illustrate some of the unintended consequences we can have sometimes when we think of health systems interventions from one perspective only. And so, I think, for example, when you look at some of the efforts around domestic resource mobilization or innovative financing and leveraging private capital, towards expansion of coverage or expansion of community health workers, I think sometimes we forget that the health workforce is the #1 recurrent cost in most countries. And so if we're looking at short-term financing to fill a long-term recurrent cost need, there's inherently going to be a sustainability issue at some point if we don't think that through. Similarly, I think given the success that some countries have had with scaling up community health workers, Ethiopia comes to mind, and really rolling those out, there's this movement to nationalize community health workers, mobilize them throughout the countries, really scale that up. But, I think some of the issues that Susna even touched on, if we don't understand how we're going to fund them over the long term, or really even what the long-term vision is for community health workers as we roll out facilities or as we move forward with more permanent structures for care. Do we keep those community health workers? Do we have a plan to transition them into the facilities? I think we really need to think long-term for how we want to do that. I also think that there's this issue of prioritization and working with ministries. Ministries of health, I think, are very, as are donors, very want to say that anything is less of a priority than something else. But at the same time, the way you're financing your health system, the way you're paying your attention says something about your priorities. And so I think we need to be a little bit more forward-leaning in how we acknowledge that we have a set of priorities and what those priorities are and how we decide, and then how we then roll out the resources to address them. And so that may mean, rather than trying to roll out community health workers nationwide, we're focusing on certain areas of the country for which we have the sustainable financing, can cover the recurrent costs, and then growing out from there as more longer-term domestic resources are mobilized. I also want to touch, though, on the multisectoral nature of the health workforce in and of itself. So again, I think this points to where there's both opportunities and challenges. So, at the end of the day, health is a labor-intensive endeavor. Even with growing use of technology, I don't think that the basic fact that it requires a lot of labor to deliver healthcare in countries is not going to completely go away anytime soon. I think that labor often comes from women. Often youth are employed to address those labor. That's really important, and you think about sort of development writ large in country is providing a source of labor for women, a source of labor for youth in a sector that is not going to reduce its need for labor anytime soon. And so that is an important opportunity for development. But that opportunity, in order to capitalize it, requires partnerships with educational institutions that train these workers, requires the solid financing and governments and leadership of the health sector to prioritize those investments, to identify paths, to take down barriers to access to the education and training. We've found, back on the community health workers theme, we've found that those programs are most successful when the people working in the community come from the communities themselves. And so in order to mobilize people from the communities, we have to figure out how to get them training. And oftentimes the same barriers that we have to getting healthcare out is the same to getting training for the people within the community, even if it's low-level training. So I think this was just an excellent set of questions for me to really sort of crystallize the fact that health systems are complex. They do require sort of looking across and looking from various perspectives, thinking multisectorally, but also, having this long-term vision for where we want to go with the work that we need in order to achieve the overall health and development goals that we're all working towards.
Great, thank you. Health system strengthening is so complex, like you've all been discussing. Sorry to push you on this, but if you had to kind of summarize, your concluding thoughts and what you would like to leave the participants with, what would it be? Sara, I'll start with you.
Thank you very much. Not a challenging question to end on, I guess. I mean, I guess the longer that I've worked in this field, the more I feel that institutional capacity within countries is absolutely key to all of this. I mean, whether we're talking about transition processes and building capacity to take over roles that donors have previously performed, or whether it's about multisectoral collaborations or managing relationships with the private sector, all of it really comes back to people on the ground in the country having the skills, the systems to be able to figure this out for themselves. And, you know, there's no perfect health system. There's never going to be one. They're continuously evolving. So this thing about having the sort of capacity in country and through sort of long-term relationships between embedded organizations within that context, which I think comes back a little bit, Susna, to what you were saying about the model of development assistance. So all of that seems really key to me. And I know that it's been threaded throughout the HFG project, but I think it absolutely has to be front and center to the work that we all do going forward.
Thank you. Kelly.
Sure. So I think we've touched on, you know, this theme of transition throughout the day, and I think it's worth sort of thinking back to the way our administrator is framing sort of this journey to self-reliance. And, you know, we're not necessarily at USAID talking about transitions away from donor assistance, but more transitions in the relationships that we have with countries. And defining self-reliance as a country's ability to plan, manage, and resource their own continued development. And so I really like that framing. I think it resonates very nicely with health systems, because if we can build country capacity to plan appropriately, to manage their health sector, and then build in the resources through domestic resource mobilization and actions like that, I think that really is the definition of self-reliance. And I think there's a role for donors to play in that journey, but really sort of looking at that as a transition in our relationship and how we're engaging with them will be really important. Mm-hmm. And then, sorry, there was just one other thing I was going to say that resonated with me from the previous session, which I just want to reiterate. I think Catherine said it, is seizing opportunities. I think that's important not only in the transition space, but in health system space as well. I think there's a lot of needs, there's a lot that can be done, and a lot of times the best interventions are the ones that people are motivated and energetic on and willing to work on. And so I think seizing opportunities is really a key point as well.
Thanks. Susna, your concluding thoughts?
Building on these points, these are all excellent points. I think I'll also address maybe one of the questions was, what's the Gates Foundation role in this space in terms of health system strengthening? And want to mention that I think if you ask Bill, you know, a few years ago, his focus was on vaccine financing, polio eradication, and system strengthening didn't really necessarily bubble up to the top. But now when you ask him, so what's the focus? What should be the focus going forward in the next 10 years or so? He says primary health care system strengthening. So he's using primary health care as the lens through which he's trying to think about system strengthening. And we're currently underway with a lot of visioning exercises trying to envision what should be primary health care, what's the primary health care of the future. And of course, it involves a lot of technology at its core, and a lot of efforts to look at disruptive solutions as well. But one of the things that I've seen with Bill and Melinda, especially as they come out to countries, they're really interested in learning and understanding and getting a sense of this complexity. And I think there is this recognition that, sure, we're going to need these disruptive tools. They're going to be very useful, and there's so many of them that we can try to see how we can adapt. But it's also the incremental work that we do, the incremental stuff, the boring stuff. I think someone had mentioned in the previous session, things like public financial management, things like setting up terms of references for working groups. I don't think that they get their due credit, but it's a combination of the disruptive. There's no single magic bullet, and also the incremental work. I think that we really need to see how we can piece together in terms of system strengthening moving forward. And I know the Foundation definitely wants to step into this space, but wants to do so in a way that's value added.
Great, thank you. Thank you so much, Kelly, Sara, and Susna. And please join me in thanking the panel.
Ladies, well done. Thank you. And let me invite you to go ahead. What an extraordinary day we have had together. And we now want to kind of bring this to more of an official close. And in order to do that, please let me invite once again HFG Project Director Bob Fryatt to offer some closing comments and appreciations. Bob, you're so welcome.
Thanks very much. That was a terrific panel. I'm a bit worried about trying to follow that. We thought we'd pick out a few quotes from the day. I mean, you heard some great closing comments in that last session. Do we have the slide? And just picked out a few personal sort of observations. What I found quite interesting is that there's a lot of reference to legislators and parliamentarians and such like, which I found very interesting. It came up around mobilizing resources. It came up in about getting advocacy for TB in Ukraine. Next slide. And another one that came up that I thought was quite nice, being sort of working around technical assistance, the idea actually technical expertise can be used to sorry? Okay. All right, so where are we? Can we go back? Back. Right, stop. Okay. Thank you. So, yeah, the idea that you actually can create links by in-depth technical expertise. I thought it was a very nice comment on the panel about South Africa. That despite all the problems, and I've worked in South Africa, it's very difficult. Someone who really knows what they're talking about can help get people together and make solutions happen. Next one. There's a nice quote here about resilience and actually in self-awareness, which I thought I had to put in about, given the fact that resilience is high on our agenda. I like the comment this morning from our COP in Vietnam about governance is implicit in everything we do. I'm not sure the governance specialists would agree with that, but now we can make it explicit. But I think it's great that we're getting to the point where we can really say that. I think someone just picked up on this in the last panel, but the idea that came from Catherine Connor about regarding transition, we need to seize the opportunities that are important to that country. I thought it was a great quote. And then lastly, yes, and this is something that resonated with me, because we've been talking about transition, and we're talking about donor transition and transition of relationships. That's a great phrase. And this came from Dr. Mengistu, from the regional manager in the Department of Health and Government of Ethiopia. We might be talking about transition, but we're not talking about saying goodbye. We're going to stay together. We're a global public health community. And he came up with this wonderful final line about together we will take it to another level. I thought it was great, yes, and that's going to happen no matter where the funding comes from. And it resonates with me because 30 years ago I worked with an NGO and we started transitioning there to local organisations. I'm still in contact with them. I'm still helping them mobilise resources. I think we're part of a global group that will keep on working together. So that's just a few little personal remarks about what I've seen today. Thanks very much to all the panelists. Thanks very much for your contributions and questions. And I'd like to also, before I give a few final thanks to the organisers, I just want to call out the people in the HFG that have been involved in this sort of wonderful 6 years. It's been, obviously, I work with APT Associates, but it's also been Avenir Health, Broad Branch Associates, DAI, John Hopkins Bloomberg School of Public Health, R4D, RTI International, and the Training Resource Group, TRG. It's been a great journey working with you all, and thank you very much. But finally, I want to thank some of the key people that have been organising this event. There's been actually quite a small army working on this. So I'm not going to list them out, but there's a few people that I think need some special recognition. Our Director of Communications Knowledge Management, Jen Leopold, thank you very much. In USAID, her counterpart, I think, more Jen Jackson, who works in communications for the Office for Health Systems. Not Jen's still here. I'd like a little, on a personal note, I'd just like to thank Nicole Barsikowski, who 1 year ago said to me, we need to start organising the End of Project event. And I said, what? No, but Nicole, thank you very much. She's also been organising, helping me organise it. And lastly, to our moderator today, Laura Geyer, I think she's done a tremendous job. So finally, big round of applause to Laura. Thank you very much. Thank you very much, everybody, and thank you for coming.